Welcome to Season 4 of Inflammation Nation. My name is Gráinne O'Leary. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. A very warm welcome to today's episode of Inflammation Nation. Today's episode is all about juvenile idiopathic arthritis, and I'm delighted to be joined by Dr Kathy Gallagher, who is a paediatric rheumatologist based at Children's Health Ireland at Crumlin. Kathy graduated from Norwich Medical School back in 2011. She then went on to train as a general paediatrician before specialising in paediatric rheumatology. Kathy, thank you so much for joining us today on this really important topic of juvenile idiopathic arthritis. So I'm going to start today's episode by asking you, what exactly is juvenile idiopathic arthritis and how does it differ from other forms of arthritis?
Gráinne, thanks so much for inviting me here today. It's fantastic to come here and talk about juvenile idiopathic arthritis, or JIA as it's commonly known as. So what is JIA? So it's essentially a chronic autoimmune disease that causes persistent joint inflammation in children and young people under the age of 16. And it's the most common type of arthritis in children and can lead to joint pain, swelling, stiffness, and that potential for long-term joint damage. Now, the exact causes of JIA is unknown, but it's believed to involve a combination of genetic and environmental factors that can just trigger that immune system to attack the healthy joint tissues. You asked me, how does it differ from other forms of arthritis? So JIA occurs in children and adolescents, so before the age of 16, while those other forms of arthritis like osteoarthritis and rheumatoid arthritis typically affect adults. And then there's that autoimmune nature that we talk about when we talk about arthritis. And like rheumatoid arthritis, JIA is an autoimmune disease, but it is a distinct condition with different subtypes, which hopefully we'll cover later in this podcast. And osteoarthritis, on the other hand, is a degenerative joint disease caused by the wear and tear, and you often hear of adults having that osteoarthritis, and it doesn't have that autoimmune process. And then I suppose there's those systemic symptoms that you see. Some forms of JIA, like systemic JIA, can cause that fever, rash and inflammation in other organs, whereas most adult arthritis generally just affects the joints. And again, JIA can go into remission with treatment, especially if managed early, whereas osteoarthritis, worsens with time, and rheumatoid arthritis tends to be lifelong. And I suppose I alluded to it earlier, but the subtypes in JIA has several subtypes, which the other types of arthritis that we talk about, such as osteoarthritis and rheumatoid arthritis, don't.
Can you tell me a little bit more about that? Because I think for people listening, they might be thinking of JIA as one disease, but of course it's not. And that's something we wanted to discuss a little bit more in detail today. It's really an umbrella term for lots of different types. So can you tell us a little bit more about that?
Yes, Gráinne, JIA, there's, as you rightly say, it's an umbrella term, and there's several different subtypes, and each with their distinctive characteristics, to be honest. So if you break down the main subtypes, first of all, we have oligoarticular JIA, and that's the most common type. About 50 to 6% of cases are that. And what that means is that it affects 4 or fewer joints within the first 6 months. So less than 4 joints, essentially, within the first 6 months. And it typically involves those large joints, knees, ankles, wrists, and it's often symmetrical. So one side is more affected than the other. And the other thing that's distinctive with oligoarticular JIA is that uveitis, that eye inflammation, is a concern as part of that subtype, and it may lead to vision problems if we leave that untreated. So that's important that children and young people get their eyes screened when they have arthritis. And in terms of prognosis for oligoarticular JIA, many children can outgrow it, but the joint issues and or vision problems can persist for some young people. Then we have another type that's called polyarticular JIA, and that affects 4 or more joints within the first 6 months. And it can be rheumatoid factor positive, and this is a blood test that we do in clinic at diagnosis. or it can be actually rheumatoid factor negative. And it involves both large joints, but also those small joints. And often you can see it in the hands. And it's often symmetrical. So this is both sides of the body that it affects. RF positive cases are more severe and tend to resemble that rheumatoid arthritis that we see in adults. And again, the prognosis can persist into adulthood, especially in rheumatoid factor positive cases. And we have another subtype. Yeah. There's quite a few here, Gráinne, but we've got enthesitis-related arthritis. So it involves inflammation of the entheses, where the tendon and ligaments attach to bones. And it primarily affects the boys, the over 8-year-old boys, and it's common in the lower limbs, such as the hips, knees, and feet. And it's associated with a HLA-B27 gene. So again, it's a blood test that we do at diagnosis and can develop into ankylosing spondylitis in adulthood. That's another form of arthritis that in adulthood. And some of the symptoms of enthesitis-related arthritis can be back pain, stiffness, Achilles tendonitis, and again, possible eye inflammation, that uveitis that we talk about. And then we move on to sort of psoriatic JIA. So that's associated with psoriasis, so that skin condition that we can see. Or if there's a family history of it, actually, you can fit into the psoriatic JIA category. And this can affect small and large joints again, and sometimes it can be asymmetrical as well, so just one side of the body. The interesting thing about psoriatic JIA that sometimes you can see nail changes, so that pitting and ridging. And often as doctors we talk about dactylitis, which is sort of the sausage fingers and toes that you can see. And again, the children and young people can have skin rashes, so the psoriasis themselves. So there's a few things to look out for on the examination as a doctor. And it can actually precede or follow a psoriasis diagnosis as well. And then the second last subtype is systemic JIA. And that's a really interesting subtype. And actually, we've started to refer to it more again as Still's disease. And it's actually the most severe subtype, but less common, about 10 to 15% of JIA cases. And what's interesting about systemic JIA is that it causes high fevers, mainly in the evening. And it's associated with sort of these salmon pink coloured rashes. And again, there can be inflammation in organs such as the heart and spleen and liver. And joint inflammation may not be the initial symptom either. So sometimes children just present with the fever and the rash, and the arthritis develops later. And there is a serious complication with systemic JIA, and that's called macrophage activation syndrome. So it's something that happens if the immune system is overactivated. So we're always, looking out for that sort of complication that can occur, and that's the most severe type. And it's good to have these subtype categories because it helps us speak the same language, but you can move from one to the other. So just because you're diagnosed with that diagnosis doesn't mean that you will keep that for life. Sometimes you can move through the subtypes, and sometimes we term that undifferentiated JIA. So it can be quite confusing for the patients and families when you move from one category to another. But these subtypes are helpful. They're not ideal, but they are helpful in helping us, bring the families and young people on these journeys.
And what you've described there is, obviously several subtypes, and then lots of different symptoms that can be present as well. So can you tell us a little bit about how JIA is actually diagnosed?
Yes, it's a very good question, isn't it? Thinking about the symptoms, first of all, and then thinking about the diagnosis. So, as a parent, I suppose the things that you'd be looking out for is joint-related symptoms, first of all, so that pain and stiffness and swelling, especially in the morning or after an activity. Sometimes there's a limited range of movement in these joints and difficulty moving some joints, and they can be warm and inflamed. And some of the other younger children may be limping, but they may not verbalise that pain. So this is where it becomes a challenge. Systemic symptoms, so that when I say systemic symptoms, that means the fever, the salmon pink rash, And that comes and goes with the fever, fatigue and weight loss, and poor appetite, swollen glands. That's really what I'm describing with systemic JIA. And then, I have to mention the eye-related symptoms. So especially in oligoarticular JIA and enthesitis-related JIA, you can get inflammation of the eyes, which can cause redness, pain, blurred vision, or light sensitivity. But children are often asymptomatic with uveitis, so that's why the regular eye examination is really important. And in terms of diagnosis, I wish there was one single test, and there's not. And it's really based on clinical evaluation, symptoms, and ruling out conditions. And in my practice, and people will hear me say every joint, every time. So when a child comes to clinic, they have a full detailed musculoskeletal examination so that we examine every joint every time. And that's really, the clinical examination is really key in diagnosing juvenile idiopathic arthritis. And people often ask me about blood tests as well. There's no definite blood test for JIA either, but some markers can support diagnosis. So people may have heard of ESR or CRP, which can indicate inflammation in the blood. And then, as I mentioned earlier, the blood test of rheumatoid factor. And also there's another blood test called ANA, and it can be often positive in the oligoarticular JIA, so those kids and young people with less than 4 joints affected, and that can be linked to uveitis risk. And I also mentioned the HLA-B27 gene, and again that can be associated with an enthesitis-related JIA, and that's a blood test. So all these things are tools to help you, come to a diagnosis. And people ask me about imaging as well. Like, doctor, can you do an X-ray, MRI, ultrasound? They're all really helpful in assessing that joint inflammation and help rule out infection or those other joint diseases. And again, I'm going to mention about the eye examination. So when the child goes to the ophthalmology clinic, they use a slit lamp test, and it's essentially used for detecting uveitis, which again can be silent, as I mentioned. But I think the important thing to stress about JIA, or to emphasise, is that JIA is a diagnosis of exclusion. So it's important to consider other differential diagnoses first. So infections or other autoimmune conditions that can mimic JIA symptoms. So that kind of brings me on to talk about sort of the diagnostic criteria. So really the symptoms have to be there for 6 weeks, at least 6 weeks. The onset has to be before 16 years of age, and there has to be no other identifiable cause. So, really, if you think about that can be quite a long time for, 6 weeks is actually a long time if you've got a child with a hot, painful, swollen joint. And then early diagnosis and treatment then is crucial, really, to prevent that joint damage and other complications that we can see.
And in terms of, obviously JIA, we know that the diagnosis can happen at any point under the age of 16. Are there particular age groups where diagnoses are more common?
Yeah, there is actually. So the oligoarticular JIA, so those children who are less than 4 joints, the little toddlers are, and a younger age group are more affected with that. And then enthesitis-related arthritis is, the over 8-year-old boy. And systemic JIA kind of has 2 peaks that we often see as well. So yes, it's a diagnosis we see actually from a young age, because that's the thing, Gráinne, people say to me, but your young people don't get arthritis. Children don't get arthritis, but actually, we do see toddlers with arthritis, and right up to that 16 years of age. So I think increasing that awareness is really important, that children get arthritis too. Yeah. It's another hashtag campaign.
Absolutely.
Yeah.
So when a child or young person gets that diagnosis, can you tell us a little bit now about how the treatment comes into play for them?
Yeah, so I suppose the goal of the treatment really is to reduce inflammation, relieve any pain that they're having, and sometimes they do complain of pain, sometimes they don't. It can be really quite variable, especially the little toddlers. They just seem to get on with it, and we want to prevent joint damage and maintain their mobility. So treatment plans are again tailored to sort of the subtype and severity of the disease. And I suppose as a parent, that's why it makes it complicated to understand the sort of, I think, arthritis in general in young people, JIA. And I think then if you think of the subtypes, it is helpful to think where the treatment is going. So in terms of medications, first of all, there's medications that help control the inflammation and prevent that disease progression. So non-steroidals, so anti-inflammatory medications, so NSAIDs, they're the first line for mild cases. So we're talking about Nurofen, we're talking about naproxen, and these help reduce pain and inflammation, but they don't stop disease progression. Then we have another type of medication called disease-modifying anti-rheumatic drugs, or often we say DMARDs. And methotrexate is the most commonly used DMARD, and we give this as a subcutaneous injection on a weekly basis. So parents are actually trained up to give this injection at home by our specialist nurses. And this helps prevent that long-term damage, joint damage. And methotrexate, it does require regular blood tests to monitor full blood counts and liver function because it can have an effect on them. And then we've got another category of medications called biologics, and these are used in more moderate to severe cases when that methotrexate's ineffective, and it targets actually certain parts of the immune system to block that inflammation that we see with JIA. There's lots of different examples of those because there's different subcategories. There's what we call TNF inhibitors. So people might be familiar with etanercept, which is Enbrel, or adalimumab, Humira, or there's other sort of IL-6 inhibitors. This is sort of where they target your immune system, such as tocilizumab. And then there's another drug that we commonly use in systemic JIA, which is anakinra, and that's an IL-1 inhibitor. And then, generally people know about the use of steroids in arthritis, and steroids are used for severe inflammation or those systemic features, that the high fevers we see in systemic JIA. And I suppose steroids can be given orally. They can be given intravenously, so through a vein via a cannula. But we also give joint injections for children and young people with arthritis. So there's depending, on the age of the child and which joint is involved. This can be done under general anaesthetic or under Entonox, which is, that's done in the medical day unit. And some children get great relief from the joint injections as well. But, I couldn't do my job without having a fantastic MDT around me. So a multidisciplinary team, and it involves physio, occupational therapy, psychology. We have a medical social worker, we have a big team around, and they're so important for our children and young people and families. The physiotherapist there helps maintain joint mobility and think about muscle strength and flexibility. And you have your occupational therapist who will sort of look at the child's daily activities and whether they need any help or support in certain areas. Sometimes, they have hand therapy if their hands are affected, and splints can be used as well. So, the MDT, that multidisciplinary team approach is really essential with JIA.
And you mentioned there about physiotherapy, and just to kind of draw that one out a little bit, obviously in terms of physiotherapy itself, in terms of, a prescribed treatment for a particular child, can you just tell me a little bit more about the importance of that, and also, physical activity in general? Because I know that's something that I suppose we're always really keen in Arthritis Ireland to promote and to, I suppose, to dispel the myths that might sometimes be present in relation to, staying active.
And you can see the logic behind it. If you've got a hot, painful, swollen joint, okay, we rest that joint because we don't want to do damage to that joint. But actually, we know that, we want to encourage that gentle, joint-friendly exercises. So, I'm often talking about swimming and cycling. They're fantastic for strengthening condition of the muscles and to keep them strong and prevent that stiffness that can be associated with arthritis. So, really, that's the myth-buster question there. Encourage activity, basically, and I think it's important for us all to teach children to kind of listen to their bodies and balance that activity with rest during their flare-ups. And try to make their routine easier.
When it comes to, sport, children nowadays and young people are, generally very engaged in sport, probably more so than they have been in previous decades. Are there any sports that you would not recommend a child play?
No, actually. So living with JIA, yes, it can be frustrating and challenging for children and young people, but actually we actively encourage our children and young people to do what they love, and that they're not going to do joint damage and listen to their bodies. But no, look, children, we want to promote an active and fulfilling life for these children and be able to do what they want.
Okay, that's really great to hear. And I think for parents listening, that would be such solace to give such a positive message. Stay active,
exactly,
do what you love. Yeah,
because I think it's as I said, that JIA diagnosis can be very overwhelming, and I think we can't shy away from the reality that it is a chronic condition, and there will be hospital appointments no matter if they're in remission or not, because they'll need to see the rheumatologist and the team, and then as I mentioned, the eye screening as well. So there's hospital appointments for these parents, and really it's we know it's a journey. It can be a bit of a roller coaster at times, but look, really can't emphasize enough to lead that active and fulfilling life.
So let's just talk a little bit more about how JIA might affect a child or young person's daily life and activities. Can you tell me a little bit more about that?
I think, like any chronic condition, JIA can affect the daily life of children. From my point of view, you're prescribing children and young people these medications, and they're sometimes, for example, methotrexate is like a weekly injection. We usually suggest to give it on a Friday because of the side effects that can be associated with it. So that can be very difficult for the child and young person. So medication burden really is there. So that's one aspect to think of it. Then you sort of have to think about their day-to-day living, so their daily routine, which often involves school. And, that we as a team support the children and young person at school, but also that, parents liaise with school as well, to just talk about JIA and what it means for their child. Because sometimes, they do need little breaks to sort of move and keep, to prevent that stiffness. So I suppose each child is very different. And as we said then, in terms of activities, we actively encourage the activities, because we know after school activities is a big thing for the school going child, and we really encourage them to keep active with their activities. And then look, they have to come to their appointments. There's and that's with the medical team, and then they may have physiotherapy, occupational therapy. So we also understand that there is the appointments, missing time off school to come to appointments. So there's many aspects that it can affect their daily living. But we hope that there's support there, that families can reach out either with each other or with other professionals to try and bring them on this journey together.
I'm always conscious that it's a difficult role for a parent, and it's a different journey. It's obviously very difficult for the child or the young person. But for parents listening to this, what would be your key advice to them, to help their child or young person cope with life with JIA?
I often reflect on that one, to be honest, because, that diagnosis of JIA, when they come to hospital and they've been at least waiting, that 6 weeks or longer, and they come to hospital and get that diagnosis, and someone may have mentioned to them on this journey, we think this is JIA, and then to get that diagnosis on the day and meet lots of different people in the team, it has to be overwhelming. And, with the right support though, they go on a journey. And my advice is really to educate yourself and your child, and talk about it and learn about JIA, and the treatments and potential complications, to sort of make an informed decision, and teach your child, depending on their age obviously, but to understand their condition and why they're taking their medication, because you do notice sometimes children are diagnosed at such a young age, and they're on medication for several years, and then they get to a point where they start asking questions, and it's really important to sort of re-educate and talk to them about that journey. and encourage them to ask questions and get involved in their healthcare, and equally to tell them, tell us how they're feeling about their condition. And I suppose a big one for me as a rheumatologist is, encourage your child to take the medication. We know it works, and help your child take their medications on time to prevent those flare-ups and potentially joint damage. So whether that's reminders on their phone or, some sort of, chart, but just explain the importance of the medication in simple terms for them. This helps keep your joints happy and strong. Children need to hear this, these sort of positive reinforcements, and as a parent as well, keep them active. That's a really important at home, and teach them to listen to their body, as I said earlier, and support them in their sort of emotional side of the diagnosis and living with JIA. So listen to them, validate their feelings, because it can be frustrating at times, and especially if they feel different from people in their class or their peers in the different groups they're in. But encourage them to get out there and maintain friendships, and reach out to support where they can get it. And parents as well, they can also be active in monitoring for flare-ups as well. So look out for the pain, the stiffness, the fatigue or fevers. Think about their regular eye examination, so looking for those complications that can arise, and keeping an eye on their growth and things like that. So definitely a lot for parents, to take on board, but there is ways they can help their child cope, I suppose, with the condition.
Hey, no, thanks for that. That's really helpful. It's fair to say that this space has seen, I suppose, a lot of developments in terms of medical treatment of JIA in kind of recent times. It's really transformed how children and young people are treated. Can you tell us a little bit about those recent advancements and how that's impacted the treatment of JIA?
Yeah, it's a exciting time for JIA. We've got to know a lot about JIA. Look, there's still unanswered questions, but biologics have transformed the lives of our children and young people with JIA. And I think that's been the biggest changer for us. There's more biologics available, and that's sort of the medical side of it as well. But equally, I think we have to recognise that JIA, people understand now that children and young people get arthritis as well. So that increased awareness amongst communities and the public is so important as well. So for me, that was the biologic, but that increased awareness, I think, in the public, just to know that children and young people get arthritis as well.
And just in terms of looking at sort of a long-term kind of outlook, and I suppose I'm not asking you to look in a crystal ball here, but I suppose it is something that parents ask. They're maybe looking at their child with this condition, and they're wondering, well, what is the long-term prognosis? So can you tell us a little bit about that long-term outlook for a child that's diagnosed? We often hear about the word remission, or that word burning out, and you hear parents asking those questions.
Yeah. Yes, and you're exactly right. Especially when a child and young person is diagnosed with arthritis, the question is, oh, doctor, will they grow out of this? And this is very hard to predict. As I talked about the subtypes, there is indicators that can tell us about the future for that child and young person. So, for example, if they're ANA positive, there may be more risk of uveitis, that eye inflammation. Rheumatoid factor positive, tends to mimic the rheumatoid arthritis into adulthood. So there is little factors that can tell us. HLA-B27, for example, is related to the enthesitis-related arthritis, but it is definitely, we can't predict at this moment in time when the child walks into the clinic room. I can't say what the future has in store. There is children out there that do achieve clinical remission off medications, but equally there is some children then that have a more difficult journey, as I alluded to, sort of the roller coaster from earlier on. Look, we're in a world where we are researching more into JIA, and it's an exciting time for the future. But again, this emphasises, doesn't it, the importance of research and the research projects, and to be able to look at the factors that does affect prognosis.
And of course, children don't stay children for their entire lives. So we talked about JIA being a diagnosis under the age of 16. So can you tell us a little bit about what happens when a child, reaches 16?
So we call around that time, the age of 16, the transition process. So a young person with arthritis then will transition across essentially to the adult services, and there's a process involved in this. There's in some areas they have adolescent medicine that helps with this process, and then we have to sort of prepare the family and young person for that. So again, not all children will go into adult, in the rheumatology service, but some will. And it's obviously a key stage for the child because, they're 16, they have school, key exams. So it is a process and can be difficult and challenging at that time. But again, it's getting the supports around them. But yeah.
And how do you do that as a rheumatologist? I'm sure that when the child is younger, most of your communication, I guess, is with the parents. And if you like, the parents are so actively involved in the treatment and management of the disease with the child. How do you manage that process with the parents and the young person?
Yeah,
as they become as they move into that phase of their lives.
Yeah, and often they're getting into that phase where they're questioning their diagnosis, they're questioning the medication, questioning everything, and rightly so. They're living with this disease, so they, that's where education again is so important, to sort of sit down the young person to what they understand, because for them they've been taking this medication and it's been working, but the question. So there's definitely a re-education piece around that. And then there's things about, again, about medication, encouraging that child and young person to get involved with giving them their own medication, rather than their parents or carer giving it, that they start giving their own medication. And then it gets to a point where suddenly they're arranging their own blood tests and they may be calling the GP to get a prescription, or, ringing our nurse line to say, look, I'm having a problem. Can you help me with this? And then, again, it's giving them the resources and tools to be able to deal with this transition process. And so those are the kind of things that you initially start. And then suddenly, you've had that tridactic consultation for years. So which means that, it's the sort of the doctor, the parent or carer, and then the young person. And suddenly then the next thing, it's just the young person, you and the young person as a doctor and the young person. And, the parent may or may not join the consultation. And I think these are really important things as part of that transition process, and that, you check whether they understand what's happened in the consultation, and they have an opportunity to ask questions as well. Perhaps some questions they don't want to ask in front of their parents as well. So yeah, transition, sort of that adolescent medicine, it's another aspect I actually really enjoy, bringing the child and young person on that, and the family on that journey.
So my last question really is about the future for the treatment and management of JIA. When I ask you that question, what comes to mind in terms of what the future might hold?
I think the future is bright. Even the last 5 to 10 years, how advances have come about in JIA and the management of JIA, I think, the only way is up, and actually the future is very bright, and hopefully we'll be able to target our treatments even more for these children and young people. And I think that's so exciting. And again, just really that awareness that JIA is a chronic condition. Children and young people get it, and just people getting engaged with the research and that awareness out there. I think the future is definitely bright. Too excited to explain, to be honest. It's good. Yeah.
Well, on that note, I'd like to thank you very much, Dr. Kathy Gallagher, for joining us today on this episode on JIA. Thank you so much.
Thanks a million.
That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or as they always say, wherever you get your podcasts. For further information about arthritis, you can visit our website, arthritisireland.ie, or contact our helpline on 0818 252 846. See you next time. Inflammation Nation is supported by Pfizer and AbbVie.